So let's take a look at the upper. This is, incidentally, those of you that need to market, which every therapist I know of should be, you need to market what you do to the orthopedists and to the family practitioners. This is one of the greatest ways of them sending you a patient for further evaluation, because the doctors all look at these motions, but they never combine them. And as a therapist, when I went to school, we never learned to combine nerve provocation with joint motion, ever. And I think we learned about looking above and looking below for problems, but we didn't think about the two connections. And now that I've done this with the orthopedist locally and even in the lower extremity with the podiatrists, I've found that we are seeing a plethora of nerve patients. In fact, they now call me the nerve guy, which I don't think the neurologists are happy about. But the idea is that when they see one that doesn't fit or shows the signs I'm going to show you now, they know it can't be their shoulder alone. And the greatest part is we've stopped some unnecessary surgeries from happening when it was the wrong diagnosis. Okay, what we're going to do is I'm going to have you, and I'll guide them with the uninvolved sometimes just to help them so they'll know what it looks like. I want you to go ahead and bring that arm just right up next to your head. Now, if they choose not to roll their hand out, I get this question sometimes, or they choose to do it down. You'll see even Bob, when he's testing patients, have them in different positions. I tend to allow them to move in their own motion pattern. We're just trying to find something, not correct something. So go ahead and just bring that up next to your ears for me, like we kind of did there. Okay, and back down. Beautiful. Is that okay? That's not painful to you at all? Okay. What I'm going to do next is I'm going to very gently fixate the shoulder. We talked about this already. I am not pressing this down. There are some people who teach this drive down. Problem is I never know how much I've driven it down based on my fatigue, based on my coffee input, based on whether I'm in a hurry. So I'm going to hold it here. Now, that would automatically stop the normal rotation of the scapula, which means we're not going to get full range normally. And what I look for is how she does with that. And sometimes they'll get a click, like she just did. No panic. There's no extra charge for the noise that she makes. So I'm going to put this right here and let her come on up nice and easy to that side. Again, the non-involved side. You can see she's fighting a little to get there. That's normal, because I'm not letting her move with normal scapulohumeral rhythm. When I do this, I'm holding down the plexus under that coracoid. So as she comes up, it's putting it on a provoked position a little more. Now, then I could very simply add her neck. Now, I've normally already looked at, does she have neck motion? But let's go ahead and take this to the side. How are we doing? Does that hurt you at all? Okay. Do not produce pain. If you bring this over and you produce pain, you will get muscle guarding, especially when you go to the involved side. Now you don't know what's going on anymore, because I just bring it up. How are we going with that? We okay? Yeah. Now, let's go ahead and bring this arm up to the side now one more time. Now with that, she moves her shoulder and all the way back down, just a little bit more into the frontal plane, because she can't quite abduct it perfectly, and she's a great, patient. She's trying to do what I ask. And when that happens, it's because now she's coming up to that end range of her nerve, so she's protecting it.